Tvam Samvo Manansi Janatsa. Meaning, let us walk together harmoniously, let us talk together harmoniously, and let us think together harmoniously. So that is our, what we are doing now. We are into the third day of webinar, jointly being conducted by Indian Radiological and Imaging Association, Preventive Radiology, Association of Malayalam Movie Artists, AMMA, and Swasthi Foundation. This curtain raiser program related to breast cancer is from 1st of October to 30th to 2025 for the Global Prevention Onco Summit, which is going to be held on January 2026. So today's topics are the role of diet, lifestyle, and exercises in prevention of cancer by Dr. Nithin Verghese Abraham, and difference between Western and Indian system of screening by Dr. Arun Mohan. So now we have got two guests. Srimati Parvathy Sivankutty was supposed to join. She has not joined. Maybe she'll join later. And we have got Gayathri Suresh with us as chief guest. She's a Malayalam cine actor who has done some memorable roles in and on screen. So on behalf of everyone present here, I invite Gayathri Suresh to speak a few words.
Thank you so much.
Over to you, Gayathri.
Yes. എല്ലാവർക്കും എൻ്റെ വിനീതമായ നമസ്കാരം. ഇന്ത്യൻ റേഡിയോളജിക്കൽ ആൻഡ് ഇമേജിംഗ് അസോസിയേഷനും അമ്മയും സ്വസ്തി ഫൗണ്ടേഷനും ഒരുമിച്ച് നടത്തുന്ന ബ്രസ്റ്റ് ക്യാൻസർ അവയർനെസ് മന്തിലെ ഇന്നത്തെ വെബിനാറിൽ പങ്കെടുക്കാൻ സാധിച്ചതിൽ എനിക്ക് ഒരുപാട് സന്തോഷമുണ്ട്. ഇത്രയും പ്രഗത്ഭരായിട്ടുള്ള ആൾക്കാരുടെ കൂടെ എന്നെ കൺസിഡർ ചെയ്തു എന്നുള്ളത് എനിക്ക് ഒരുപാട് അഭിമാനം നൽകുന്നു. പിന്നെ ഇന്ന് ഞാൻ ഇതിൽ പാർട്ടിസിപ്പേറ്റ് ചെയ്യുന്നത് അമ്മേനെ റെപ്രസെന്റ് ചെയ്തിട്ടാണ്. അമ്മയിൽ ഏകദേശം 250 ഫീമെയിൽ മെമ്പേഴ്സ് ഉണ്ട്. അപ്പൊ അതുകൊണ്ട് തന്നെ ഈ ഒരു ഇനീഷ്യേറ്റീവ് ഞങ്ങൾക്ക് വളരെയധികം ഹെൽപ്ഫുൾ ആവും. ആൻഡ് ഞങ്ങൾ എല്ലാവരും വളരെ ഗ്രേറ്റ്ഫുൾ ആണ് ഫ്രം ദ ഡീപ്പസ്റ്റ് ബോട്ടം ഓഫ് അവർ ഹാർട്ട്സ്. താങ്ക് യു സോ മച്ച്. ഇന്നത്തെ ഈ കാലത്ത് ഇന്റർനെറ്റിന്റെ ഓവർ യൂസും മിസ്യൂസും ഉള്ള ഈ ലോകത്ത് ഇത്രയും നല്ല കാര്യങ്ങൾക്ക് വേണ്ടിയിട്ട് സോഷ്യൽ മീഡിയ ഉപയോഗിക്കുന്നു എന്ന് പറയുന്നത് വളരെ പ്രശംസനീയമാണ്. പിന്നെ ഇനി ക്യാൻസറിലേക്ക് വരികയാണെങ്കിൽ ഞാൻ എന്റെ കാര്യം പറയാം. എപ്പോഴൊക്കെ എനിക്ക് ഈ ക്യാൻസർ പറഞ്ഞ ഈ തോട്ട് എപ്പോഴൊക്കെയോ മനസ്സിലൂടെ പോകുമ്പോ ഞാൻ അതിനെ മാക്സിമം ഇഗ്നോർ ചെയ്ത് സപ്രസ് ചെയ്ത് എനിക്ക് ആ ചിന്ത പോലും വേണ്ട എന്നുള്ളൊരു തരത്തിലാണ് ഞാൻ അതിനെ മാറ്റിവിടാറ്. എനിക്ക് വളരെ ഭയത്തോടു കൂടി കാണുന്ന ഒരു അസുഖമാണ് ക്യാൻസർ എന്ന് പറയുന്നത്. അത് എനിക്ക് മാത്രമല്ല മോസ്റ്റ് ഓഫ് ദി ആൾക്കാർക്കും അത് അങ്ങനെ തന്നെയാവും. പക്ഷെ ഇന്നത്തെ കാലത്ത് ഇത്രയും എത്ര മാരകമായിട്ടുള്ള അസുഖങ്ങളാണെങ്കിലും അതിനെ തരണം ചെയ്യാനും ഓവർകം ചെയ്യാനുമുള്ള അഡ്വാൻസ്ഡ് ആയിട്ടുള്ള ട്രീറ്റ്മെന്റ്സ്, നല്ല ക്വാളിറ്റി ഡോക്ടേഴ്സ്, നല്ല ഹോസ്പിറ്റൽസ്, നല്ല അഡ്വാൻസ്ഡ് ആയിട്ടുള്ള ടെക്നോളജി നമുക്കുണ്ട്. സോ പൊതുജനത്തിന് ഒരു ധൈര്യം പകരാനും നിങ്ങൾ ഒറ്റയ്ക്കല്ല, ഞങ്ങൾ എല്ലാവരും ഉണ്ട് നിങ്ങളുടെ കൂടെ എന്നും അവരോട് പറയാനും ഇതിനെയൊക്കെ പറ്റി നല്ല എലാബറേറ്റഡ് ആയിട്ടുള്ള ഇൻഫർമേഷനും എക്സ്പ്ലനേഷനും നൽകാനും ഈ ഇനീഷ്യേറ്റീവിന് സാധിക്കും എന്ന് ഞാൻ വിശ്വസിക്കുന്നു. അതുപോലെ നമ്മൾ പറയും പ്രിവെൻഷൻ ഇസ് ബെറ്റർ ദാൻ ക്യൂർ. ഇന്നത്തെ ടോപ്പിക് മാം പറഞ്ഞ പോലെ തന്നെ നമ്മുടെ ലൈഫ് സ്റ്റൈൽ, നമ്മുടെ എക്സസൈസസ്, നമ്മുടെ ഈറ്റിംഗ് ഹാബിറ്റ്സ്, സ്ലീപ്പിംഗ് ഹാബിറ്റ്സ്, നമ്മൾ എന്തൊക്കെ ആഡ് ചെയ്യണം, നമ്മൾ എന്തൊക്കെ ഡിലീറ്റ് ചെയ്യണം, നമ്മൾ എന്തൊക്കെ മാറ്റങ്ങൾ കൊണ്ടുവരണം ഈ ബ്രസ്റ്റ് ക്യാൻസർ പ്രിവെന്റ് ചെയ്യാം എന്നുള്ളതിനെ കുറിച്ചും ഒരു വളരെ നല്ല ബോധം ആൾക്കാർക്ക് പകർന്നു നൽകാൻ പറ്റും എന്ന് ഞാൻ വിശ്വസിക്കുന്നു. ഇത് മാത്രമല്ല, ഇത് കൂടാതെ ഒരുപാട് സാധ്യതകളുള്ള ഒരു ഇനീഷ്യേറ്റീവ് ആണ് ഇത്. എനിക്ക് ഇതിനെക്കുറിച്ച് വളരെ ആധികാരികമായിട്ട് സംസാരിക്കാൻ എനിക്ക് അറിയില്ല. അതുകൊണ്ട് തന്നെ ഞാൻ എൻ്റെ വാക്കുകൾ നിർത്തുകയാണ്. ഈ ഒരു വെബിനാർ 1-ാം തീയതി മുതൽ 30-ാം തീയതി വരെയുള്ള വെബിനാർ വളരെയധികം വിജയകരമാവട്ടെ. അതുപോലെ തന്നെ നിങ്ങൾ ജാനുവരിയിൽ നടത്താൻ പോകുന്ന ഓൺകോ സമ്മിറ്റ് വളരെ വിജയകരമാവട്ടെ. സൊസൈറ്റിക്ക് അത് വലിയൊരു ആശ്വാസമായി മാറട്ടെ, വലിയൊരു പ്രതീക്ഷയും കോൺഫിഡൻസും ആയി മാറട്ടെ എന്ന് ഞാൻ മനസ്സറിഞ്ഞ് പ്രാർത്ഥിക്കുന്നു. Once again, thank you so much for having me here. Thank you.
Thank you, Gayathri. That was wonderful. ശരിക്കും പറഞ്ഞാൽ ഒരു പേടിക്കേണ്ട ആവശ്യമില്ല. Because many of the doctors, they have come out with lot of programs, webinars like this. So we are all with everyone. നമുക്ക് എല്ലാവരും വേണമല്ലോ, എല്ലാ ഇതിലും വേണം. So they are giving us such a support. So thank you once again, Gayathri.
Yes. Thank you. Bye.
Bye. So please, just if you have time, please continue with us for some more time and just listen to the talks. That will be more fruitful. Okay, thank you. Thank you. All the best.
Thank you, ma'am.
So we'll go to the next session. I think Mrs. Parvathy Sivankutty has not joined yet. So we'll go to the expert talks. So I invite Dr. Nithin Verghese Abraham, consultant breast surgeon, Department of Surgical Oncology, GG Hospital, Trivandrum, to enlighten us on his topic, the role of diet, lifestyle, and exercise in the prevention of cancer. Over to you, doctor.
Thank you, ma'am. Hi.
Welcome.
Hello. Good evening, everyone. Respected Srimati Parvathy Madam, our chief guest for today, film actress Gayathri Suresh, other fellow presenters, and other respected doctors and people who are part of the webinar for today. As part of breast cancer awareness program, we have listened to two important topics in the last 2 days. On the first day, the answer sir actually has explained in detail and has given valuable inputs regarding the importance of early detection and the number of lives it can save on a yearly basis. So yesterday, Gayatri Madam actually explained to us regarding the risk factors associated with breast cancer. Now, most of the risk factors which are associated with breast cancer are non-modifiable, which includes family history and genetic factors. But now the question is whether there are any other risk factors that in a whole can reduce the long-term risk associated with breast cancer. The answer is yes, there is. In a collective, they are referred to as modifiable risk factors. So that brings to my topic. Hope my presentation is visible.
Yes.
It's visible.
So that brings to my topic, the role of lifestyle, diet, and exercise in prevention of breast cancer. Myself, Dr. Nithin, and let me get into the topic. So breast cancer now is the commonest malignancy among women globally. It has surpassed lung cancer as the leading cause of global cancer incidence in 2020. Estimated 2.3 million new cases, representing 11.7% for all cancer cases, is now found. These are the few statistics that is associated with breast cancer. The current trends point out that a higher proportion of the disease is occurring at a younger age in Indian women as compared to the West. All population-based cancer registries have shown a significant increase in the trend of breast cancer. Now, our goal mainly should be to empower individuals with evidence-based strategies to reduce this risk. So the focus of my presentation for today, for the webinar today, is how the modifiable risk factors, mainly diet, physical activity, and weight, can significantly impact the long-term risk reduction in breast cancer. So the first part of my topic is diet. So most significant risks for breast cancer, such as family and reproductive history, which I already mentioned, cannot be modified. But behavioral risk factors, which includes alcohol, smoking, physical activity, body composition, and dietary habits, can definitely be modified. So now the dietary components, which I'll be mentioning today, which increases the risk and decreases the risk, is nothing new. It's all that we know. But still, we as people don't realize it and still have not changed our dietary habits. So the dietary habits, the dietary components, which increases the breast cancer, has been demonstrated with high consumption of red meat. Red meat mainly includes high myoglobin content. So it gives a red color. So that is why it is referred to as red meat, which includes pork, beef, lamb, and goat. And along with that, the processed meats, which includes bacon and sausages, have found to have increased higher risk of breast cancer, along with animal fats, which is including ghee and butter, refined carbs, which is white rice, pasta, pastries, and sugary drinks. Now, the reason behind why these are considered to have an increased breast cancer risk is these contain saturated fat, trans fat, and amino acids, which stimulate insulin, and high insulin levels have been linked to breast cancer. Now, this is a pictorial representation representing on the left side to have of a unhealthy diet and one on the right side, which is found to be a healthy diet. but on the left side, it's actually good for the palate. Not actually, it's more tasty for the palate. So that is why still people actually take this on a daily basis. On the right side, it might not be might not be good for the palate or tasty for the palate, but still considered as a healthy diet. So what is on the right side? The right side the components mainly include the fruits, which are berries, apple, pear, vegetables, green leafy vegetables, and cruciferous vegetables like cauliflower, cabbage, and broccoli. Whole grains, which is barley, oats, and millets. Millets mainly includes ragi. നമ്മൾ പുല്ലുപൊടി എന്നൊക്കെ പറയുന്ന അത് same. All these food particles mainly contain dietary fiber. Now, why these food particles or why these dietary components has a decreased risk of breast cancer? The reason behind is fruits, vegetables, and lentils. Lentils and payarvargangal are rich in antioxidants, vitamins, folate, dietary fibers, and phytochemicals. These substances are reported to be involved in inhibiting carcinogenesis through the alteration of estrogen metabolism. So there are studies which shows that a Mediterranean style diet reduces the breast cancer risk and improves survival and quality of life, particularly in postmenopausal patients. So, what is this Mediterranean style diet? It includes mainly high consumption of fish, vegetables, beans, boiled potatoes, fruits, olives, vegetable oil, and low intake of fresh juice. Now, the inflammatory dietary patterns, which includes high intake of sugary soft drinks, refined grains, which is white rice, white flour, which is maida, white breads, cakes, pastries, along with red and processed meat, ghee, hydrogenated fats, which includes packaged snacks or bakery items, and deep fried fries, are found to have increased breast cancer risk, especially in premenopausal and overweight postmenopausal women. Now, studies have shown that lacto-ovo vegetarians, which is a term which includes those people whose diet includes plants, dairy, and eggs, have shown a lower breast cancer risk compared with meat eaters and lacto vegetarians. Use of dairy products such as milk or yogurt also found to have reduced risk of breast cancer. Now, the reason behind that is basically contains potential anti-cancer fat conjugated linoleic acid, which can hinder the growth and increase of cancer cells. Now, these are also important sources of vitamin D and calcium, which are well-known cancer protective effects. So overall, adopting healthy dietary habits such as diet rich in unrefined cereals, vegetables, fruits, nuts, and olive oil, while limiting saturated fats, red meat, and processed food, improve breast cancer prognosis and survival outcomes. Now, all these individual dietary components, like red meat, carbohydrates, and fatty acids, are occasionally linked to breast cancer. But evidence indicates that a noteworthy connection is normally associated with a cumulative food consumption, that is, on our weekly or monthly dietary habits, and along with that of breast cancer. So now that brings to the second part of my topic, the lifestyle changes. Now, associations are found between increased risk in breast cancer and various lifestyle factors, which include smoking. Now, tobacco use, which is leading cause of cancer incidence and death from cancer, that is not only associated with breast cancer, but any other cancer. Studies evaluating a possible association of tobacco use with breast cancer have demonstrated mixed results. This is due to the confounding of alcohol use. However, a longitudinal study by American Cancer Society demonstrated that breast cancer incidence was 24% higher among smokers than non-smokers and 13% higher in former smokers than non-smokers. And also a stronger association was noted between smoking and breast cancer risk among women who started smoking before the birth of their first child. Now, alcohol. A research study which combined of 53 analysis on the links between alcohol and breast cancer onset found that with each increase of 10-gram daily alcohol consumption, women increase the risk of developing breast cancer by 7%. Another lifestyle disease is referred to as obesity. Obesity is associated with higher risk. Obesity is associated with higher risk of premenopausal estrogen receptor negative breast cancer and triple negative breast cancer. Now, there are two meta-analysis of women with TNBC, that is triple negative breast cancer, demonstrating 80% and 43% higher risk of developing TNBC, respectively in obese than in non-obese premenopausal women. Over 100 studies observed the association between weight and fat distribution and development of breast cancer have found that women who are overweight that is a BMI more than 25, or obese, that a BMI of more than 30, have 30 to 50% higher risk of developing postmenopausal breast cancer compared to women with a normal body mass index. Now, in addition to these, in highly skilled professionals, there are two factors which are also considered to have high risk, which is a decreased sleep and also. Now, the next part of my topic is exercise, which is the power of movement. So, this is one part of our life which is currently right now undervalued. Now, because women who had done exercise such as walk, work, or any other physical activity have a decreased probability of breast cancer risk by 13% than women who do not do any exercise daily. The main mechanism behind it is estrogen reduction, insulin sensitivity, reducing excessive growth factor signals, immune boost. So this walking exercise increase the production of natural killer cells, that is the NK cells, which reduces the risk of breast cancer, and also decrease weight and BMI. That as per I've discussed in the previous slide, decreases the risk of breast cancer. In addition to that, physically active breast cancer patients demonstrate better survival and a lower likelihood of recurrence. Performing physical exercise can also mitigate the side effects of cancer treatment, such as fatigue, anxiety, and depression. Also, it helps to improve quality of life. The precise mechanisms linking physical training and cancer are basically not fully understood yet. But the hypothesis is skeletal muscle releases various myokines that seem to possess a direct anti-tumor effect. So, in conclusion, the most effective preventive strategy is the combination of a healthy diet, lifestyle modifications, and daily exercise. Small, consistent changes create significant long term risk reduction. So, a very important question that most of the people ask, or most of the people say, is that we don't have time on our daily routine, on our daily life for exercise. But WHO recommends that a 150-minute brisk walking. Now, what is brisk walking? That is walking at a speed fast enough to elevate your heart rate and breathing, but still allows you to hold a conversation. That is referred to as brisk walking. 150 minutes per week is the daily recommendation by WHO for a adequate exercise. That is good enough to actually improve your health. Now, if you listen as 150 minutes per week might sound like a long duration, but when you break it down, it is 30 minutes for 5 days in a week, which is not actually a long duration. So we need to pledge now that we will start by making one sustainable change in our daily routine and lifestyle this week and this month for a better future. Thank you.
Thank you, doctor. That was wonderful. Actually, we should be following all this, whatever you have suggested. And about the diet, what we would like to know is, we are talking about Mediterranean diets. So how can we adapt it to Indian diets? You talked about, I mean, you were talking about pulses and all. So why Mediterranean diet? Why is it so important? Just a brief thing.
Actually, the Mediterranean diet actually has dietary components, which actually includes beans, boiled potatoes, fruits. That in our Indian diet also we mostly follow it. So when
Yeah.
you look at it, the Mediterranean style diet is actually strongly or kind of similar to what we have in our Indian diet. But the current lifestyle actually prevents it from having most of these dietary components, and we prefer dietary components which are actually tasty for a palate but not might not be good for a health.
Okay, for a common man, when you say the Mediterranean diet, it can have negative
That
approach to it.
because Dr. Nithin has
Right.
pointed out Mediterranean diet, because most of the studies have been done in that. So what we should take from that is in our food pattern also, what we conventionally used to eat is actually a healthy diet, where the amount of vegetable is more. The conventional food that we used to eat, the sambar, avial, or all those things, which has a higher proportion of vegetables. But now we have moved from that to a fast food style, where we need to eat a tasty food in a very short duration.
Especially the younger crowd.
Younger
Talking
crowd.
about
So,
the younger
yes.
crowd. Yeah.
So we
Mostly.
have to go back to
Mm.
our traditional way of eating. There are a lot of obstacles for following that. It's a very costly way for eating, because for the modern youngster, it is very easy for them to get food from a fast food restaurant than cooking at home. Cooking at home is much more costly. You have to buy vegetables, you have to buy all the ingredients, you have to cook. But if you put that effort on a longer period, over a longer period of time, the risk of breast cancer reduces, because cancer doesn't happen overnight. As I have shown in the first day, the cancer have a period, a duration of 15 to 20 years of developing in our body. For a low risk type of, less aggressive type of cancer, whereas very aggressive type of cancers have a duration of 3 to 5 years. So in both the cases, we have an option of halting the progress at any of this time by changing our lifestyle. So it need not be a Mediterranean type of diet, but the diet with more of fruits, vegetables, and less of refined
Right.
foods and carbohydrates.
Mm.
Why Mediterranean food? Because the most of the population-based studies have been done in those population. The such studies have not been done in our population. If we could have done some studies, then we could have pointed out that this diet
Family.
definitely helps. So the basic message is,
Sure.
we have to take food which contains more green leafy vegetables and fruits. A rough estimate of how much fruits and vegetables that we have to take is about 400 gram per day is required for one person. That will give a 30-35 gram of fiber that is required for a healthy diet, and reduce the protein content of the food to 60 gram per day. That is 1 gram per kilogram body weight for a person. So reduce the protein content, increase the fruits and vegetables. So a rough estimate is a plate model. If you take a plate, divide the plate into half. The half should be the green leafy vegetables and fruits. Remaining half we can divide into 2/3 and 1/3. 2/3 we can go for the rice, bread, wheat, all those things. And the 1/3 for the fat and oil with the protein. That is a rough estimate of what becomes a healthy diet that we can plan in our plate itself.
Correct.
When we take the food to eat.
Thank you. Thank you.
You're muted,
Yeah.
madam.
Yeah, I know. So we'll go to the next topic. That is, I invite Dr. Arun Mohan, Assistant Professor, Department of Radiodiagnostics and IR, Sree Gokulam Medical College, Trivandrum, to speak on difference between Western and Indian screening.
Yeah.
Over to you, Doctor.
Good evening, ma'am.
Good evening.
Hope I'm audible.
Sorry? Yeah, you're audible. You're audible.
Good evening, Parvathy ma'am, Gayathri ma'am, Dr. Rijo sir, Ansar sir, Nithin sir, Karthiyayani ma'am, other dignitaries, and dear delegates. It's a privilege to join this great initiative and to join today's session on breast cancer awareness. So at the outset, I would like to appreciate all the office bearers and members of AMMA, Swasthi Foundation, and IRIA Kerala for taking the initiative to launch such a noble and meaningful program. I'm very sure that such type of collaborations would definitely improve the awareness of breast cancer detection among the people, and finally it will lead to early detection of cancer. So my topic, this is just a beginning only. A great, huge event, Global Onco Summit is yet to come. So we are all are eagerly waiting for that session, for that event. So for today, coming to today's session, my topic is the key differences between Indian and Western screening modalities. I hope my slides are visible, madam. Ma'am, are the slides visible?
Yes.
Yes, slides
it's
are
visible.
visible.
So before starting, I would like to emphasize on a point. What do you mean by screening? What is the difference between screening and diagnosis? What is screening? Screening is any test. It can be a blood test. It can be a scan. It can be a clinical examination. Any test or examination which helps to find a disease in people who don't have any symptoms. So implementing it on breast cancer, the main goal is to detect the breast cancer as early as possible before it causes any symptoms to a patient, like a lump, like a pain, like color change, etc. So why screening is important in our part of the world? We all know the breast cancer numbers are on a significant rise in India, especially in younger age group. And in younger group, especially more aggressive type of breast cancers are being detected now. We all know in our country, most of the patients present at an advanced stage of disease when the disease has already been spread into armpits or lungs or bones or liver, etc. So this late presentation is directly decreasing the long-term survival of our patients. The main point is the lack of awareness among patients in India. Patients are not unaware of what are the symptoms of breast cancer. What are the symptoms they should be more worried about. Most of the patients think that if the lump is not causing any pain to them, it's a harmless lump. But this is a myth. This has to be corrected. Most of the time, breast cancers are painless. So this awareness, breast awareness, is the single most important factor responsible for the better survival in Western countries. The next is lack of efficient screening programs in our country. And finally, early identification is a key factor in breast cancer treatment because early initiation of treatment is the most effective measure to control breast cancer. So about incidence, Dr. Nithin has already mentioned breast cancer is the most commonly diagnosed cancer among women, and here we know the major part contributed by breast cancer, which comes around 27%, followed by cervical cancer. It is primarily is a disease of an age. That means the incidence of breast cancer significantly increase as your age advances. So what is the difference in age of presentation and disease in Western countries from our country? So as we all know, the incidence of breast cancer is very much higher in Western countries as compared to India. And the median age of presentation is typically at an older age group, for example, that means at a 60 to 65 age group. And the stage of diagnosis, most of the cases, about 60 to 70% of the patients presents with an early disease. That means stage 1 or 2 because of the excellent screening programs they are following. And subsequently, it will result in a lower mortality rate and a better survival rate. Coming to India, in contrast, though the overall incidence is low and the median age of presentation is approximately a decade younger to that of Western countries. That means average age of presentation is 45 to 55 years. In India, most of the patients present with a lump which are having a larger size. That means mean size is 4 centimeters. And majority of the patients, in contrast to Western countries, often more than 60% presents with an advanced stage, that is stage 3 or more, with already the tumor being spread into other parts of the body. This in turn will lead to a poor prognosis, and the reason for late detection is mainly the lack of screening programs and also the non-participation of women in this screening programs, which are conducted at an institutional basis or in or camps or campaigns like that. And subsequently the poorer survival rate. So Western countries, while they focus on screening asymptomatic women, in India, more reliance is being given for early diagnosis when the women are being referred by any clinicians or when the women are seeking help for when they feel any lump. This is a key difference between screening, the aim of the screening. So what are the screening modalities available in our part of the world? Mainly mammography, it is a gold standard in many Western programs. There are many modifications for the mammogram. Mammogram can be conventional mammogram. It can be digital mammogram where you get a better depiction of the breast tissue. There is also other option called an advanced option called digital breast tomosynthesis. It is nothing but a 3D mammogram of the breast when you take images from all sides of the breast and the images are reconstructed to create a 3D image. It will give definitely better results, but at the expense of more cost. Breast self-examination, I'll come to it in the next slide. Clinical breast examination, CBE, it's nothing but a clinical examination done by a doctor or a nurse or a trained assistant. It can be used in low resource settings for screening purpose. Next is ultrasound. Ultrasound is not superior to mammography, but it's always an adjunct or complementary modality to mammography. It is more useful in young females who have a more denser breast. When you have a denser breast, thick breast, your mammography is very less sensitive for such women. So in such patients, we can use ultrasound as an adjunct. And second use is that we can characterize the tumors or growths which we have detected already in mammogram. We can measure the size of the lesion. We can measure the distance of the lesion from the nipple or from the skin, or we can look for the lymph nodes in the armpit. For such further characterization of the tumor, those features which are demanded by the surgeon, we can use ultrasound for a adjunct. And finally, MRI is a very high sensitive modality, but definitely expensive. It has specific indications. It is often used in high risk patients. So here I forgot to show, this is the mammography machine. Here patient is being undergone mammography here. This is the ultrasound machine here, and this is the MRI machine in which the patient is being positioned in prone position with her tummy down to take the images of the breast.
Dr. Arun,
is not
your
seen,
slides are not moving.
Slides are not moving.
Now?
No.
No.
Okay.
Okay.
Yeah, you
Yeah.
have to play.
Yeah.
I think
Now?
the lower bottom, the play button, then only it will come in the full screen.
Now is it moving, sir? No.
It's moving, but it's not full screen. We are not able to appreciate. It's not clear.
Now, sir?
Clearly visible.
Visible?
Yeah,
Slides are very
a
small.
multiple slides view only. I think you can increase the zoom to, it is 28%. You can increase the zoom. Lower bottom. Lower bottom, your zoom is 28%.
28%, yeah. Down.
Below, yeah.
Below, oh, yeah. Yeah, that will be better.
Now, sir?
Yeah.
Now it's better.
clear.
Yeah.
Okay. So this is the mammography machine, and this is the USG ultrasound machine, and this is the MRI machine in which the patient is being positioned prone to take the images. So these are the mammography images of both breasts. This is the MR image of both breasts, and this is the ultrasound image of a small growth here. So coming to breast self-examination, it is nothing but creating awareness or familiarity with one's own breast. You should be well aware of your own breast, how the breast look and how the breast feel on your hands. You should be very well aware. And a self-examination can be done on a monthly basis during bath or any time in front of a mirror. The best time is to do the self-examination after the end of your periods. And you should look for symptoms such as lumps, any contour irregularity, any dimpling, any skin discoloration, or changes in the size of your breast. Self-examination can be very important way to find a cancer early when it is more likely to be treated successfully. And we should train our health workers the skill of conducting breast self-examination, and they should disseminate this knowledge to other people. And but still, American Cancer Society no longer recommends this breast self-examination as a screening tool. But it is in developing countries like India, it is a much more easier and feasible approach. So coming to mammography, it is currently the best available population-based method to detect breast cancer in an early stage. There is a concern among many people that mammography uses ionizing radiation and it can cause harm. But it's a myth only. The ionization dose which is used in breast mammography is very low. It is clinically insignificant. And mammography has a sensitivity of about 60 to 70%. And most of the cases, mammography can reveal the tumor before it is clinically palpable in an asymptomatic human. So before doing mammography, consulting a doctor is very important. You should never go and do a mammography by yourself, because mammography can reveal a lot of non-specific findings which can generate a lot of anxiety for no reason. Most of the lesions doesn't need any intervention. So you should always consult a doctor before and after taking your mammography. So coming to Western recommendations, the most commonly used recommendations are USPTF recommendation, American Cancer Society, and World Health Organization recommendations. These recommendations are usually organized population-based screening programs on a government or national health service level with the help of mailed invitations and registries. For example, a group of women who are supposed to are living over a residential area, they are being invited to undergo mammography with the help of mails, with the help of posted letters, etc. They are being invited. These screening mammographies are being conducted in portable trucks which has mammography machines, and they do mass screening mammography. And these machines, these scans are later analyzed in a tertiary hospital, and those people with positive findings are being recalled for further investigation. So they have a proper registry, they have a proper system to screen all the patients in their country. And the primary tool being used is, as you said, it is screening mammography. And the age group in which they start screening is mostly at 40 years and followed by every 2 years up to 74 years of age. And supplemental screening can be done with the help of MRI or ultrasound in high-risk women or those with denser breast. And the coverage under this screening is very high. It exceeds more often more than 70%. American Cancer Society recommends screening mammography before the age of 45 is optional, and from 45 to 54 years, so they recommend annual screening. And after the age of 55, they recommend biennial screening. WHO recommends mammography every 2 years for women aged 50 to 69 years. And the sad part, while coming to India, we don't have any national organized government-funded screening programs or guidelines covering all the people. Screening is limited by the access, cost, and lack of awareness. And our screening is mostly concentrated in urban and private healthcare settings. In India, we use predominantly opportunistic screening, that is, women comes themselves to get screened or being referred by a doctor. So the coverage is also very low as compared to 60 to 70% Western countries. Our coverage is only 1 to 5% in the target age group. And the primary tool we use is clinical breast examination and breast self-examination. Clinical breast examination should be started at an earlier age group, that, for example, from 30 to 35 due to younger peak age. And mammography can be used only for opportunistic screening, generally advised from the age of 40, often annually, because the mammography availability is limited, especially in rural and low resource settings. So what are the key challenges in India? We all know the limited access to modern diagnostic facilities in rural populations. Secondly, the limited infrastructure, workforce, and quality assurance programs. Insufficient number of these mammography units in rural areas. Several socio-cultural factors. The people are having variable health literacy and so many cultural barriers among different religions. Lack of specialist radiologists and technicians is also a contributory factor. Lack of awareness many times is the main culprit, because most of the time the disease is totally asymptomatic until it becomes palpable. So, and the lumps are mostly painless also. So we should make people aware of the clinical symptoms of the breast cancer. We should make them aware what are the screening modalities available. We should make them aware what are the treatment options available, and we should reach them in an effective manner. Then only patients will come for screening. The low public knowledge of breast cancer symptoms and and we all know there are a lot of stigma and modesty. Most of the people are very reluctant to undergo breast examination, especially with male radiologists. There is a huge stigma of being rejected by the community or partner. They are very afraid of loss of their breast. They have a prevailing taboo of not discussing this breast cancer in a topic in a open forum, and they mostly don't believe that there is no effective treatment for breast cancer presently. As Manju Vaidya has correctly pointed out in the first day, women always keep their health priorities to a later time. Their health is often not prioritized. So again, younger median age and denser breast significantly reduce mammography sensitivity. And finally, the economic factors, cost factor is a major factor, major problem in our country, because mammography in Western countries, mammography is widely available and is reimbursed with the help of many insurance systems. So in our country, it is not still practical. So just few guidelines of the National Comprehensive Cancer Network, NCCN guidelines. They have classified people into 3 categories: 25 to 40 years of age with no family risk or no other. They are having average risk factor only, no other significant risk factors. From 25 years to 40 years, clinical breast examination should be done every 1 to 3 years, and self breast examination every month. It's a must. The range of 1 to 3 years comes from the fact that during your early 20s or late 20s or early 30s, the risk of developing breast cancer is very less. So in that time, I think you may consult a doctor for clinical examination once in 3 years. That will be okay. But once you cross 35 age group limit, you may need to consult a doctor every year. Next category is females above 40 years with no familial or other increased risk factors. In such patients, again, self-breast examination is a must every month during a fixed day, preferably after the menses, after the menses, before standing a mirror. Self-examination is a must. Then clinical breast examination, it's a must annually by a qualified or trained medical personnel. It's a must. And coming to mammography, as I already pointed out, only after consulting a doctor, it is preferred annually. But in some patients who belongs to 40 to 45 age group may have denser breast. In such patients, mammography would be of less use. In such patients, ultrasound scan is more beneficial. So your doctor will examine you clinically and will decide which imaging modality is the best for you, and he or she will prescribe you the mammography. So third group, women of any age with increased risk. What are the increased risk factors? First, any history of radiation therapy to the chest, for example, for lung cancer, for lymphoma, for any other cancers. If you have undergone radiation therapy to the chest, you belong to a high risk category. If you have a family history of breast or ovarian cancer, yes, you belong to a high risk category. Again, women with genetically proven breast and ovarian cancer belong to high risk category. Again, if you have more than one first or second degree relatives with breast or ovarian cancer, again, you belong to high risk category. In such patients, in addition to breast awareness, self-breast examination, which is a must part, and clinical breast examination, which is again a must part annually, mammography can be used. With patients with history of radiation therapy, we should initiate mammography from the age of 25. And while patients having family history of breast or ovarian cancer, we should initiate the mammography by 35 years of age. And again, with genetically proven patients and people with multiple first or second degree relatives with CA breast and ovarian cancer, start mammography from 25 years. In most of the patients who belongs to less than 40 years of age, mammography will be of less sensitivity. In such cases, mostly your clinician will prescribe an annual MRI. So some frequently asked questions: what is my risk of developing breast cancer? Don't overthink over it. Just leave it to your doctor. Just consult your doctor. Give him the history. let him examine, let him take the history from you and decide which risk category do you belong to. Just because there may be one or two family members, one family member in your having history of CA breast doesn't make you a high risk individual. So many other factors needs to be considered. Let the doctor decide. Second question, I am above 40. Should I just go and do a mammography? This has already been addressed. No, please don't do. Consult a doctor, because mammography has its own pitfalls. It needs to be interpreted and reported correctly. It can have many small, unimportant, non-cancerous conditions which can make you more anxious. And if you don't know how to read the report, how to interpret the impression, it will be a source of immense anxiety too. So better to consult to a doctor first. Let him decide the mammography. It should be done or not. Which doctor should I consult? It's a very commonly asked question. You can consult your family physician or a general physician. If we have a direct access to a general surgeon, okay, that's good. You can consult a gynecologist if you are more concerned about the stigmas. Again, if you can consult a surgical oncologist, it's the best. So to conclude, key takeaways: the primary difference between Indian and Western screening is primarily one of lack of resources, organization, and access. Western countries usually benefit from established, well-funded national programs, while we don't have such an organized program in India. So what are the future strategies which we can recommend? We need to have a tiered approach. That means we should implement wide-scale clinical breast examination by the trained female workers as a primary entry point. We should train our ASHA workers to do the breast self-examination, and we should make use of them. We should definitely increase the awareness of breast cancer, its symptoms, its diagnostic options, its treatment options, everything. And we should do aggressive, targeted public education with the help of community outreach programs. We have now television and mobile phones in most of the rural areas, so it's very easy now to get into the rural population. We should give much importance to reduce the stigma and encourage immediate consultation for symptoms. It's also important to educate the rural practitioners also, because they are the first line doctors who are coming in contact with these patients, and they should be able to recognize the signs of cancer and to ensure appropriate referral without causing any delay for detection. So finally, targeted mammography should be our goal. We should focus screening efforts on high-risk groups or utilize mobile screening camps or campaigns to reach underserved populations. Thank you. Thank you once again. Thank you for all the office bearers of AMMA, IRIA, Kerala, and Swasthi Foundation for this great initiative.
Thank you, doctor. That was wonderful. Actually, in Swasthi, when we conducted camps, we could directly point out whatever, the people would never come to camps. So they had to be caused, and we had to, make people come into the camp, and then, they were not aware, actually. So we had to give speeches and pull in people. There were so many stigmas, as you said, the challenges we also faced in Swasthi when we conducted camps. So anyway, it was really great, wonderful talking to you. Dr. Pradeep Kadangur had joined us. Good evening, doctor. I hope he is here.
Yeah, good evening.
Yeah. So any questions to be asked, or any queries from any side? That is it. There are no questions, nothing, no queries have come.
Dr. Arun, is there a national recommendation for this mammography testing?
No, sir. That is the main challenge. Till now we don't have a unified recommendation program. Some of the people, we have breast societies in India. We have American College of. There are institutional based programs are being followed mainly. And sir, can you just
no national program for screening, because why screening means screening is testing of entire population who are at a risk of disease. That means if we want to screen Kerala as a state, if we take, we have to screen all female population above the age of 40 up to the age of 70. That is screening. But no such recommendation exists in India or in our state for screening of either breast cancer or cervical cancer or any other cancer. But what we are doing is extrapolating screening recommendations from the Western countries where they have a national screening program which is covered in the insurance. And what we have observed is our population behaves more like Western population, because the age of menarche has increased, the age of marriage has gone up, age of first childbirth has gone up. More people, more ladies are focusing more on the profession. So all these increases and less breastfeeding. These behaviors are more of that of a Western society in Kerala. So, and the incidence of breast cancer is more on the younger age of less than 50 years of age group. So our recommendation as a society or a group of NGO to the Keralites, the population is, if you have a chance to screen, it's better you screen, because if you consider all the risk factors, the modern women of Kerala are at higher risk of developing breast cancer. But this cancer is a disease which can be completely cured if it is detected early. So that is a message that we have to give, even though we don't have a proper recommendation for screening by any government bodies. We can adopt and by extrapolating the data from the Western countries where the population behavior is, Kerala population behavior is more or less similar to that of the Western population.
Any more? Or can we wind up the session? Dr. Ansar?
Yeah, I think if there are no questions, we can wind up.
So, Srimati Parvathy Sivankutty, she had expressed her, she couldn't join the session due to some inconvenience. So, she has expressed her regret. So, with that note, let us wind up the session. Thank you, each and everyone who had joined this. The chief guest, of course, she couldn't, our Parvathy Sivankutty couldn't join. Thank you, Gayathri, and thank you all the doctors, especially the main topic experts, and all who have joined the session. Hope we'll have much more, informative sessions like this, so that when we can understand, like layman like me and all, we can understand about the pros and cons in not attending to the medical needs or whatever the symptoms. We all keep it away, as doctor said. We ladies, we have a tendency to keep it at the last. So anyway, thank you once again. Thank you, everybody. We thank IRIA, AMMA, and Swasthi Foundation. And thank you once again. God bless you all.